This conference will now be recorded.
So today we will be discussing this TOG, which is obstetric neurological injuries, which is October 2020 TOG. This TOG is actually compilation of nerve injuries which occur during childbirth. It can be because of childbirth or because of anesthesia also. So they have given both the things: individual nerve injury, what is manifestations, how to treat it, and something regarding anesthesia nerve injuries also. So the highest reported incidence of obstetric neurological injury or nerve injury, it is around 2%. So it is the highest incidence till now. In anesthesia, the risk of neurological injury is up to 1 in 25,000. Okay, so that is 0.004%. In case of regional obstetric anesthesia, like either epidural or spinal, the mechanism of nerve injury in case of obstetric procedures, so it is either by compression, ischemia, or transection. Most commonly in obstetric injuries, these are compressive neuropathies. These are the most common, and most common nerve involved is lateral cutaneous nerve of thigh. Okay, so most common mechanism is compression, and most commonly involved nerve is lateral cutaneous nerve of thigh. Other nerves which are involved, they can be either femoral nerve, common peroneal nerve, lumbosacral plexus, sciatic nerve, and obturator nerve. Most cases, this obstetric nerve damage is not because by nerve compression. So it is not caused by any procedure as such, okay, any obstetric procedure as such, but because of compression between the body structures, like between the fetal head and the bony pelvis, or like because of these positions which are used for these obstetric interventions, like lithotomy procedures or extensive hip flexion or abduction. So in that cases, because of this compression of this nerve in against the support or between the fetal head and the pelvis. So this is the most common mechanism and not as such a procedure per se. So neurological injury, to understand the neurological injury, we should basically understand the structure of a nerve. Okay. So here you can see this is the most basic part of the nerve. It is the axon or a nerve cell, individual nerve cell, which is covered by Schwann cells and myelinated. So this axon is covered by endothelium. Single axon is covered by endothelium. So axons combine to give rise to small nerve fibers. So these nerve fibers, these are covered by perineurium, and so these bundles of nerve fiber, they are again in a major nerve or a big nerve. These all fascicles of this nerve fibers, they get together along with blood vessels, so and they make a large nerve. So this is covered by this nerve, these major nerves, these are covered by epineurium. Okay, so this is the epineurium is the covering of peripheral nerve. So it is the endoneurium, perineurium, and epineurium. So it is the basic structure of this nerve fiber. While in case of nerve injuries, you also know there are three things three possible mechanisms of this nerve injuries. So one is neuropraxia. So there will be just, it is a conduction block or loss of myelin sheath. So it is a neuropraxia. Another is the division of axons. Okay. So it is known as axanthemesis. And next is the total division or cut of a nerve as a whole. It is known as neurotomesis. So it is the neuropraxia, axanthemesis, and neurotomesis. So neuropraxia, it is usually caused by milder or short-lived blunt injuries to nerves, like usually the compression neuropathies which occurs in the obstetric procedures. These are usually neuropraxia, and it refers to the damage to individual neurons and their myelin sheath, which results in a nerve conduction block, but there will be no axon or perineurium disruption in this neuropraxia. So there will be, usually it is a conduction block, but there will be no structural disruption of this nerve. Then axanthemesis, neurotomesis, this is the severe nerve damage, which is rarely caused by any obstetric injuries or intervention. So most common thing which occurs in obstetric nerve injuries is neuropraxia. So this now prognosis of this neuropraxia, it is almost complete recovery can occur with this neuropraxia because of remyelination. Okay, but it will take usually days to weeks. But in case of axontomesis and neurotomesis, usually the prognosis will be somewhat grave. But for neuroproxia, prognosis is excellent and complete recovery can occur. So for pelvic nerve or for during obstetric intervention, what nerves can be involved? So to understand this anatomy, you should know what is this lumbosacral plexus and pelvic nerves. So here just you can come to know that different nerves which are with their nerve roots. Okay, so and these are the dermatomes for this lower limb. No need to remember all this, but just to know the structure of nerve or from exactly where it arises to understand the codes of this nerve, you can go through this figure. So as I previously said, most commonly involved nerve in obstetric practices, lateral cutaneous nerve of thigh. Its root is L2, L3. Okay, so it is, and it is a totally sensory nerve. Remember, it is purely sensory nerve. Nerve root is L2, L3, and it runs under the lateral end of the inguinal ligament. So it runs under the inguinal ligament, and usually compression occurs when it exits exit the pelvis under the inguinal ligament, and it results in meralgia paresthetica. So meralgia paresthetica is the nerve injury of lateral cutaneous nerve of thigh. It is a syndrome of sensory symptoms in the lateral thigh. So lateral thigh, this is supplied by this lateral cutaneous nerve of thigh. So here the symptoms which patient reports is numbness, pain, paresthesia, hyperalgesia, and hypersensitivity to heat. Remember that there will be no motor symptoms in case of meralgia paresthetica. So whenever it's this question, actually this talk is basically for EMQs of this nerve injuries. So you should differentiate between the different nerve injuries whenever you get a question. So compression under the inguinal ligament, only sensory symptoms, no motor symptoms, and these symptoms do not cross the midline of the thigh. Okay, so important is it does not, the sensory loss do not cross the midline of the thigh, and symptoms will be reproduced by renal space. Okay, so this is the basically keywords for this meralgia paresthetica or lateral cutaneous nerve of thigh. So this meralgia paresthetica, this usually occurs during latter half of pregnancy or postpartum due to increased intra-abdominal pressure and prolonged hip flexion compressing the nerve. Other risk factors which include, these are obesity and diabetes, which increase the compression of the nerve. So treatment, basically weight loss, wear loose clothing, and in case of late gestation and labor, usually the delivery of the fetus is the treatment for this. Okay, and simple analgesia should be given. In case of more severe injury or more severe symptoms, you can give local corticosteroid injections and neuropathic analgesics like amitriptyline. Okay, so amitriptyline can be prescribed in postpartum period because it is safe in breastfeeding, and in severe cases, surgical decompression may be required. So this is the treatment for this meralgia paresthetica. Then injury to the lumbosacral trunk. So this lumbosacral trunk, it arises from L4, L5. It runs over the posterior pelvic brim and down the sacral ala to join the sacral nerves, and it contributes to the sacral plexus. So this lumbar plexus arises from L4, L5. It runs over posterior pelvic brim, down the sacral ala, and then combined to the sacral nerves to form lumbosacral plexus. So this lumbosacral trunk, it can be compressed between the sacrum and the fetal head, or during instrumental delivery like forceps delivery. Okay, so fetal malposition and CPD, these are the risk factors for these injuries. Malposition, CPD, and forceps injuries, these are the causes of this lumbosacral trunk injuries. So symptoms of this lumbosacral trunk injury, these are usually basically these nerve fibers, they form this common peroneal nerve. So this lumbosacral trunk injury patients, they have the symptoms of foot drop, but foot drop, as you know, this is usually a representation of common peroneal nerve. So how you are going to differentiate between this common peroneal nerve injury and lumbosacral trunk injury? So here, basically, you have to remember that along with this foot drop and loss of sensation over the calf and the foot. Okay, so this is the symptoms of common peroneal nerve injury, and along with that, there will be mild weakness in upper areas like knee flexion, hip abduction, hip extension, and internal rotation. So when you get this motor weakness for knee flexion, hip abduction, hip extension, and hip internal rotation, then you can have this diagnosis of lumbosacral trunk injury. While when there is only foot drop and loss of sensation over lateral calf and the foot, then it is common peroneal nerve injury. So you have to differentiate between these two, whether it is a lumbosacral trunk or common peroneal nerve. So this is a motor weakness between the hip. When there is motor weakness is there with this hip abduction, hip knee flexion and hip extension, then you can diagnose it as a lumbosacral trunk injury. So also there will be deep boring pain in the pelvis. Okay. So related to the site of injury, this can be also differentiating feature for this common peroneal nerve injury. And if the diagnosis is still unclear, then nerve conduction studies are required to differentiate between this common peroneal nerve and lumbosacral trunk. This is, as I told you, it is a compression neuropathy. So if the labor is not excessively prolonged, the prognosis is usually excellent and patient recovers within days to months. And treatment here is physiotherapy and neuropathic pain medications like gabapentin and amitriptyline. Now next is femoral nerve. So femoral nerve, the roots is L2, L3, L4. It emerges from the lateral border of lower part of psoas muscle. It runs between the psoas and iliacus muscle and pass under the midpoint of inguinal ligament. So here, see, this is the femoral nerve. Okay, so this is passing in the under the midpoint of inguinal ligament and it runs between the psoas and iliacus muscle. This is a motor nerve. Okay, so it has a motor function for anterior thigh muscles and also sensory function over the anterior thigh and medial calf. Okay, by its saphenous nerve branch. So this femoral nerve injuries, these are caused usually by stretching or compression at the inguinal ligament. So it is not caused by compression by fetal head, but stretching of inguinal ligament and compression under the inguinal ligament. It is the mechanism of injury for this femoral nerve. Symptoms of femoral nerve, basically remember, it is the weakness in the knee extension, okay, with or without hip flexion, pain, paresthetica, and loss of sensation in the anterior thigh and medial calf. Okay, usually the patient typically presents knee, giving away of knee and difficulty in climbing stairs. So this is the most important word in your question, that when patient complains of difficulty in climbing stairs, it is always femoral nerve. Also, knee reflexes will be impaired. Now, here you have to remember for this femoral nerve, the differential diagnosis. So, this femoral nerve injury, it can be bilateral in case of 25% of cases. So, when this bilateral femoral nerve injury symptoms arises postpartum, you have to do the urgent investigations to rule out whether it is because of spinal or epidural analgesia. So, to rule out any anesthetic injury or any space occupying lesion, okay, in spinal cord, so for, or in the retroperitoneal lesion, so they will also cause this compression injuries. So when this femoral nerve, when you suspect any bilateral lesion in postpartum, immediate postpartum period, you have to do urgent investigation like MRI, okay, to rule out any central lesion. Then differential diagnosis for this femoral nerve injury, it is the radiculopathy of upper lumbar plexus, that is L2, L3, or retroperitoneal lesions like hematoma or tumors. So, how to differentiate between these central lesions and radiculopathy or retroperitoneal lesions is the you have to see for other nerve involvement. So, with this retroperitoneal or radiculopathy, there will be other nerve involvement like obturator nerve or lateral cutaneous nerve of thigh. And also, these retroperitoneal lesions, they will have a back pain. So to differentiate between this femoral nerve injury and other lesions like radiculopathy or retroperitoneal lesions, you have to see for other nerve involvement and whether this patient is complaining of back pain. And if it is there, then it's not the femoral nerve injury. Management of femoral nerve injury, usually it is simple analgesia, neuropathic pain medications, and femoral nerve blocks. When this you have this difficulty in climbing stairs or this knee giving away symptom, then it can be managed with physiotherapy and knee based application for support of knee, and the prognosis is usually very excellent. Now, obturator it arises from anterior division of L2, L3, L4. It runs from medial border of psoas to the obturator canal, and then it enters true pelvis. So this is the nerve which is compressed by fetal head. See here, the nerve roots are similar, L2, L3, L4, but femoral nerve, it goes to the midpoint of inguinal ligament, while this obturator nerve, it enters the true pelvis. So obturator nerve is compressed by fetal head, while not femoral nerve. So lithotomy position, it stretches the nerve when it exits the obturator foramen. So also it predisposed to injury by lithotomy position also. So whenever you get that, it is a prolonged labor or CPD, and then you are getting the symptoms of this obturator nerve injury. So you have to know that it is this obturator. So what are the symptoms of this obturator nerve injury? It is the motor weakness of hip adductors and sensory nerve loss on the medial portion of the thigh. So medial thigh, sensory loss, and motor weakness of hip adductors. Again, this obturator neuropathy can be bilateral in 25%, and it results in isolated weakness of hip adduction and loss of sensation over medial thigh. Again, treatment for this injury is physiotherapy and reassurance, and prognosis is excellent. Then common peroneal nerve. This is the most commonly asked question in your exam, okay, regarding foot drop. So this common peroneal nerve, it arises from sciatic nerve in the posterior thigh, and it is vulnerable to compression in lithotomy supports or traumatic injury when it runs around the head of fibula to reach the anterior calf. It supplies motor muscles of anterior and lateral compartments of leg and sensory supply to the anterolateral leg and foot. So the common symptoms of this common peroneal nerves are foot drop and impaired sensation over anterolateral foot and calf. Differential diagnosis, as I previously told you also, lumbosacral trunk injuries and common peroneal nerve, you have to differentiate between the motor weakness in this hip muscles, okay? So whenever there is motor weakness in the hip muscles along with back pain, then it is a lumbosacral trunk injury. And when there is only foot drop and anterolateral calf and foot sensation is lost, then it is common peroneal nerve injury. Then another differential diagnosis is sciatic nerve injury. So this will cause hamstring weakness and sensory loss over antero, posterior, and lateral aspect of leg. So here in common peroneal nerve injury, patient have this high stepping gait. So this is again a keyword for you in the exam. The patient will have a high stepping gait. Patient have repeated trips and falls. Okay. So these are again keywords which you can find in your questions. So when there is high stepping gait, foot drop, trips, falls, and prolonged lithotomy position, it is always common peroneal nerve injury. Treatment is AFO brace or ankle foot orthosis brace and physiotherapist. Then anesthetic nerve injuries in case of obstetrics. So the nerve injuries, these are more common with epidural anesthesia than the spinal anesthesia. And the mechanism for this anesthetic nerve injury, it is usually a traumatic, okay, and where it can cause trauma to spinal cord, conus medullaris, or nerve roots because of accidental damage while the needle insertion. So the symptoms will be pain, paresthetica, anesthesia, and weakness in the distribution of affected nerve root. Other rare injuries in case of anesthesia, these are hematoma and abscess formation. So hematoma usually occur when there is a disruption of epidural venous flexus by anesthetic needle or catheter. Okay, this usually present early because this hematoma expands and it will compress the nerves in the vertebral canal. So hematoma present early, while abscesses, this is because of introduction of pathogen via in the epidural space. So the abscess will take time to develop, so they are presented later than the hematoma. But both of these are rare if you do proper practice. So here, what are the careful precautions that are needed is attention to the coagulopathies, timing of anticoagulation, and asepsis precaution. Okay, good aseptic precautions, C for the anticoagulation medications, and rule out any coagulopathies. So when you follow these techniques, these nerve injuries or these abscess and hematomas will be very rare. So the symptoms with this hematoma and abscess, these are back pain, tenderness, and bilateral sensory, motor, and autonomic symptoms. That will be also, so there will be sphincter loss, okay, and then bladder sphincter involvement and paraplegia. So the paraplegia which can become permanent also. So these injuries, these are very serious injuries. Anesthetic nerve injuries, these are very serious injuries. So whenever you get patient with any postpartum neurological symptom, how you have to triage that patient. So first of all, you have to take urgent anesthetic review, history and examination. There you have to consider what are the red flag signs. So we will come to that, what are these red flag signs. Then if you are suspecting any possible anesthetic complications, so severe pain, severe tenderness along with any muscle loss, loss of sphincter control and paraplegia, this will points to the anesthetic hematoma or abscess formation. So this requires urgent MRI. And if MRI is suggestive of any abscess or hematoma, then urgent review by spinal surgery team. If the MRI is negative, then you have to take the obstetric review. Here again, you have to take history, examination, see for any precipitating factors like forceps delivery, CPD, any prolonged labor, prolonged lithotomy position. And all these things, if it is obstetric nerve injury, usually the prognosis is very good. So for mild and improving symptom, you have to reassure for rapid recovery and follow-up. But severe and persisting symptoms, you have to refer to neurology. So when you come to the proper management of this patient, so whenever there is a unilateral sensory or motor loss without any back pain and which occurs in the distribution of a proper nerve, then this is a reassuring feature. That means it is usually a compression injury because of obstetric procedures or prolonged labor. So this symptom suggests nerve damage in the peripheral nerve. So it is an obstetric cause. Isolated postpartum, only back pain, no other symptoms, no other neurological symptoms, no motor weakness, no sensory loss, only back pain. It is the most common thing, and these have a musculoskeletal cause. So only postpartum back pain is not a feature of nerve injury. But back pain and tenderness with neurological symptoms, they should be investigated urgently with MRI and rule out any anesthetic complications like hematoma or abscess. So what are these red flag signs? So the first you have to see whether the patient have back pain or not. If the patient is having back pain, you have to see whether this patient is having other neurological features. So like if there is any muscle weakness, sensory weakness, then you have to think of central lesions. Okay. And but if it is isolated back pain, as I told you, it is a usually musculoskeletal cause and only thing the painkillers is required. Then bilateral symptoms. Presence of any bilateral nerve symptoms, it usually suggests central lesions. Okay, so it can be either retroperitoneal lesions or central hematoma formation or abscess formation. Okay, but again here you have to remember that femoral and obturator neuropathy, these are bilateral in 25% of cases. Then any sphincter symptoms. So again you have to see whether it is associated with other neurological symptoms. Okay, because central lesions like hematoma and abscess formation, they are associated with the sphincter symptoms plus neurological symptoms. But isolated sphincter symptoms that can occur in the postpartum period without any nerve damage also, like pelvic floor and sphincter weakness for like voiding dysfunction or some anal incontinence, it can occur in postpartum period, okay, without any nerve damage. Then protracted time course. Okay, so when these symptoms, these are started late, so and severe, it can be due to the abscess formation. And any presence of coagulopathy, it usually points towards the presence of hematoma. So these are the red flag symptoms which requires urgent review. So whenever the patient is not responding to routine management like physiotherapy and painkillers and neuropathic pain management, then or when the diagnosis is uncertain, you have to refer to the neurology for nerve conduction studies to decide the precise location of the nerve injury. Then, but these nerve conduction studies, these are not very helpful in first week because in acute phases, they cannot determine the severity of injury. Also, more severe injuries also, the conduction studies, these are preserved. Okay, nerve conduction will be preserved until this Valerian regeneration takes place. Okay, but after 1 week, usually these nerve conduction studies, these are very helpful for delineating the location of that nerve injury and also distinguish between this neuropraxia and exanthemesis. Okay, so you can think regarding the prognosis and its treatment. But if in the first week, if there is severe symptoms which are suggestive of exanthemesis and neurotomesis, then instead of nerve conduction study, MRI is the most useful investigation. So if in the first week only, if the symptoms are very severe, then better is to do urgent MRI to see for this any exanthemesis or neurotomesis. Now, treatment of obstructive nerve injury, I have told treatment for each injury separately, but again, this commonly, it is a conservative management. So you have to advise and reassure the patient regarding the good prognosis, physiotherapy, and support braces. Okay. Also, drugs which you can use, these are neuropathic pain drugs. These are usually safe in breastfeeding. So these are paracetamol, NSAIDs, amitriptyline, and gabapentin. Pregabalin should be avoided because there is a limited data. Remember, well, pregabalin should not be given. So other neuropathic pain management agents you can use. These are gabapentin and amitriptyline. And surgical, that is nerve grafting for any transection of nerve. Usually, most obstetric nerve injuries, they resolve completely within 3 months. Now, how to prevent these obstetric nerve injuries? So, remember that prolonged lithotomy position is a major cause of this obstetric nerve injuries. So, avoid putting the patients in prolonged lithotomy position. So, just put the patient into the lithotomy immediately before surgery or after timeout. So every 2 hours. So if it is a more than 2 hours lithotomy position is used, it is associated with increasing risk of injury. So change the position frequently in case of prolonged labor and delivery. Okay. Avoid prolonged thigh flexion. Use lower dose epidural to allow ambulation and increase women's awareness of impending nerve injury. Also, ensure timely intervention in case of obstructed labor to avoid the permanent nerve injuries and treat the shock to maintain blood pressure. So perfusion to the spinal cord will be maintained. So these are the prevention for this nerve injuries. So this is regarding the obstetric nerve injury talk. Tomorrow we will discuss some another talk. Okay. And this will complete that October 2020 talk. And then we will move to the July one. So thank you friends for attending. Bye.
Thank you.
Thank you, ma'am.